Hello, everyone. Welcome and thank you for joining us tonight. My name is Mike Rondinelli, and I am the Director of Marketing and part of the commercialization team for the SOLTIVE SuperPulsed Thulium Fiber Laser. Welcome, and tonight we have a great night tonight with a great topic. So the SOLTIVE SuperPulsed Thulium Fiber Laser and the enucleation of the prostate. Before we get into the specifics, I'd like to highlight just a quick disclaimer. This presentation is for your general knowledge and background only. Procedures using SOLTIVE SuperPulsed Laser are to be performed according to the standard technique and is left to the operator's experience and skills. Olympus makes no representations, warranties, or other expressed or implied warranties or guarantees regarding the accuracy, reliability, or completeness of the information. Proper attribution should be provided for any use of this information contained in this presentation. Under no circumstance shall Olympus or its employees, consultants, agents, or representatives be liable for any costs, whether direct, indirect, special, incidental, consequential, or otherwise. This may arise, or be incurred in connection with the information provided or any use thereof. Dr. Naeem Bhojani, the authoring physician of this presentation, is a paid consultant of Olympus Corporation and also has additional consultants and disclosures. All right. So before I introduce this evening's speaker, I have a few brief announcements. We have a number of attendees tonight, and due to this being a virtual audience, we have everyone muted except for our speakers and hosts. At any time, please feel free to submit any questions in the Q&A section. What we'll do is we'd like to have an interactive dialogue throughout this presentation. So please enter your question and we'll address it with Dr. Bhojani as we proceed throughout the night. We have scheduled approximately 1 hour for this, and it will be recorded. So we will share the presentation after the fact. And again, please post your questions throughout the presentation and the talk. All right, without further ado, I'd like to welcome tonight's physician speaker and SOLTIVE enucleation champion. He's a rising star in the international urology community with a strong reputation fueled by his thought leadership in enucleation. He performed his residency at Indiana University under one of the procedure's pioneers, Dr. James Lingeman. In 2013, this physician was recruited by the University of Montreal to develop comprehensive kidney stone and BPH programs. Today, he holds the title of Associate Professor and Clinical Researcher at the University of Montreal. He has published in stone disease and BPH while maintaining a full practice, completing well over 1,000 prostate enucleations to date. Please join me in welcoming one of the world's leading experts in prostate enucleation, Dr. Naeem Bhojani of the University of Montreal. Welcome, Dr. Bhojani, and thank you for being here tonight.
Fantastic. Thanks, Mike. Thanks so much for the introduction. Thanks to Olympus for inviting me to present this evening. I think, one of the most important things Mike said was the disclaimer. Just kidding. No, the most important thing he said was we want this to be interactive. It's really, the goal is really to help the attendees perform a enucleation procedure with the SOLTIVE Thulium Fiber Laser. So please, if at any time you need clarification or you have a question, just write it in the chat, and Mike has my full authority to interrupt me at any time. So with that, we'll get started. I just really put in a lot of videos and just generally how to do a SOLTIVE Thulium Fiber Laser enucleation of the prostate, and then sort of advanced technique, just to really try to get the discussion going. And hopefully we'll be able to talk about all of this in the next 45 to 50 minutes. So just going to go over the technology, and then we'll talk about enucleation, talk about some of the benefits of the thulium fiber laser, and then we'll, again, as I mentioned, go into advanced enucleation with the SOLTIVE thulium fiber laser, and then how you can get started. So I think, again, with the technology, this is old news now, but just keep in mind that thulium fiber laser is not the same thing as thulium YAG. laser. Thulium YAG laser is an older laser from the early 2000s, which is only used for BPH surgery, can't be used for stone disease. It's very similar to the holmium YAG laser. So the thulium fiber laser. So the thulium fiber laser is very different than the holmium YAG laser. We'll talk about the differences specifically related to enucleation. But just so you know, inside of the thulium fiber laser is a long thulium fiber. It's dotted with thulium ions. These thulium ions are activated with the diode laser. Once activated, those ions are then placed into a surgical fiber, which is then used in the patient. This is the SOLTIVE thulium fiber laser is a very stable laser. It doesn't get very hot. You don't need a cooling system. And there's a number of really nice benefits. When you compare that to the holmium YAG laser, the holmium YAG laser uses flash lamps to activate holmium ions on a crystal, which are then sent through a number of mirrors into a surgical fiber, then used in the patient. Biggest problems are the fact that if you want a high-powered laser, you need a number of cavities, and each cavity has this flash lamp. This creates a lot of heat. You need a cooling system. That's why the laser is so large, and that's why it makes so much noise. Also, because of the mirrors, it's a fragile laser. It's not as stable as the thulium fiber laser. So, number of differences that make the SOLTIVE thulium fiber laser much more user-friendly and a lot more advantages, as we'll see in a few minutes here. Again, if you look at the output of this laser fiber, because with the SOLTIVE thulium fiber laser, there's no mirrors. You get a very uniform laser coming out of the laser fiber. Whereas with the holmium YAG laser, it's very different. It's not uniform. You won't get the same output every single time. And then, as I just mentioned, the thulium fiber laser can plug into a 15 amp. So you can basically plug it in at home if you wanted. But with the holmium laser, you need that, 30 50 amp socket, which a lot of ORs don't have. I used to think this wasn't a big deal, but it actually is a really big deal. This is now, we can't even use some of the high-powered lasers that are coming out. Another really big difference between the holmium YAG laser and the thulium fiber laser is the pulse width. The shortest pulse width of the SOLTIVE thulium fiber laser is actually longer than the holmium YAG laser. So keep that in mind. And that's one of the reasons why there's a large difference, which we'll talk about. Depth of penetration, also very different. So the holmium YAG laser, which has a very shallow depth of penetration of 0.4 millimeters, the thulium fiber laser is actually shallower. Its depth of penetration is even shallower. And then lastly, the wavelengths. So wavelengths seem very similar, but the thulium fiber laser is actually at the peak of absorption in water. That wavelength is at the peak of absorption in water. So it's actually 4 times more absorbed in water than the holmium YAG laser. All of this makes for a laser that is very hemostatic. So the fact that it has a shallower depth of penetration, longer pulse width, and more absorbed in water, all of this makes the laser better for hemostasis, which is one of the main advantages of the SOLTIVE thulium fiber laser, and one of the main reasons why I switched over from holmium YAG to SOLTIVE. So just a quick background: I performed about 1,000 HOLEPs after my fellowship with Dr. Lingeman, and then about 3 years ago, when I got the SOLTIVE thulium fiber laser, I began using it for enucleation, and I haven't gone back. Over 200 now, 200 cases of SOLTIVE thulium fiber laser done. And one of the main reasons for me not switching back is the hemostasis with this laser is better than the holmium YAG laser. So just moving on into how I performed the procedure. So I tried many different settings when I first got the laser for enucleation. First of all, fiber size. I use the same fiber size that I used previously with the holmium YAG laser, so the 550 micron laser fiber. In terms of settings, I use 1 joule and 60 hertz with the short pulse for enucleation, and 1 joule and 30 hertz for hemostasis, and that's a long pulse, and that's on my right pedal. The enucleation is on my left pedal. So when you use long pulse, what you get at the tip of your fiber are these big bubbles that become very distracting when you're trying to do an enucleation. So definitely don't use long pulse for the enucleation part. For the hemostasis, the bubbles actually don't bother me, and I actually think it actually might help a bit. So, but what I've learned is that you can almost do this procedure without that right pedal. The hemostasis with the enucleation settings is actually really, really good. And just maybe ever so often I'll switch over to the hemostasis pedal, but for the most part, hemostasis takes care of itself with this laser. Indications, contraindications. So SOLTIVE Thulium fiber laser enucleation of the prostate, very similar indications as you would have with any enucleation procedure. So men obviously with bothersome lower urinary tract symptoms, prostate gland size. So anywhere from 30 grams all the way up to prostate size independent. We say the largest I've done to date is about 350 grams with the SOLTIVE Thulium fiber laser. But really there shouldn't be any limitations. I find when you get up above 350, you get into like the 400 grammars, those are quite long. And regardless of the energy source, I'm not sure it's that beneficial, but something to consider. But there is no limitation really. Anticoagulated. So I've done patients on aspirin, of course. I've done patients on Coumadin, and even Plavix. So they can be done. I always try to stop the anticoagulation, the anticoagulant before the procedure if possible. But if you can't, if the patient has a metallic valve, for example, this still can be done. There's obviously the risk of bleeding goes up, as it would with any energy source. Contraindications, obviously patient unfit for surgery. Regional anesthesia. So I just put this in just to remind me. So 90 to 95% of my cases are done under regional anesthesia. During fellowship, we did it always under general with a laryngeal mask, almost always. So I think either is fine. Regional, I find it works really well. Patients are pretty happy with not having to go under, but either is fine. Patients obviously who can be put in a dorsal lithotomy position, can't stop anticoagulation, so I don't think that's a contraindication. Bleeding diathesis, I've never done this, but again, like with homium, this you can do it, of course. Prostate cancer, so this is obviously not a treatment for prostate cancer. SOLTIVE Thulium fiber laser enucleation of the prostate is used for BPH. That being said, I've done a number of patients who either have cancer and are in retention. So, for example, I've done a number of patients who are on active surveillance for low-grade prostate cancer and are in retention with 100-gram prostate. And this works really well. Not really a problem. Definitely not a contraindication. And the other indication that I get sometimes is patients with large glands, with, let's say, Gleason 7 diagnosed, and they're waiting for radiation therapy. And the radiation oncologist actually won't radiate large prostates because the risk of lower urinary tract symptoms increases postoperatively. And so I'll actually do the enucleation, and then the patient will then go on to have radiation. So those are kind of the indications, but this is not a treatment for prostate cancer, obviously. And then, of course, patients who want to maintain their antegrade ejaculation. Patients who want to maintain antegrade ejaculation, this is probably, enucleation in general is probably not the best option for them. There are some techniques you can use, ejaculation sparing techniques, which I don't really offer. I think, you could probably get about 30 to 40% of patients able to ejaculate after enucleation if you use some of these techniques, which is basically maintaining the bladder neck, and sort of the posterior floor and some of the area around the verumontanum. There's some data to suggest that might work. So steps of enucleation. So if you're going to perform an enucleation procedure, you obviously, the two keys are knowing what the steps are, of course, and then, recognizing planes and tissues. That's extremely important. Being able to recognize tissue, prostate adenoma versus capsule, versus perforation versus is extremely important, and especially adenoma versus capsule. If you can recognize that easily, it makes enucleation very, very easy. So what are the steps? The first step is apical dissection. Actually, before the apical dissection is actually finding the plane of enucleation. So that is the key step in enucleation. It's really that finding the plane and doing that apical dissection. You know, whenever I speak to people who are learning enucleation, you know, this is what always comes up, is that ability to do that apical dissection. That's always the problem. Once you are able to figure out the apical dissection, which is really like the first 15 minutes of the procedure, the rest of it really is easy. It's quite easy, but you got to figure out that apical dissection. Part of that apical dissection is that sphincter adenoma separation, which we'll talk about later on in the advanced portion. So once you've done the apical dissection here, you've come over the top, you're at 12 o'clock. Then you're going to go head towards the bladder, get into the bladder. And then if you're trying to do a 2-lobe technique, we don't do 3-lobe techniques anymore. That's quite old. So the median lobe is basically going to go with the right or left side. So you're just going to split the prostate in two, right? Just like you do with open prostatectomy. So you do a 6 o'clock, you do a anterior commissure, and then you do either a 5 o'clock, 6 o'clock, or 7 o'clock groove. If you have a median lobe, it'll be a 5 or a 7 o'clock groove. And if you have no median lobe, you just do a 6 o'clock groove. And then finally, do your lateral posterior enucleation and push the prostate into the bladder. Now, I don't do that anymore. I've moved over to the en bloc procedure. I used to think that this was more an advanced technique, but you know, I've completely changed my mind. I think en bloc is actually easier. You don't cut the prostate in two, so it doesn't bleed as much. It's faster. I think, you know, I think en bloc is really the way to go. You can't en bloc, in my opinion, every prostate. Usually around 150 to 200 grams, I'll have to split the prostate in two, but you know, anything under 150 shouldn't be a problem. And even above 150, if you can't push the prostate into the bladder, you can always morcellate within the prostatic fossa, which is not really that difficult. And as long as the hemostasis is really good, which it is with this laser, it's not a problem. So let's get into some videos. So apical dissection, you know, again, most important part. So the first video you're going to see is the finding the plane of enucleation. So this is a 130 gram prostate. Here's the verumontanum. Here's the sphincter. Oh, I always start about 1 centimeter proximal to the verumontanum. The reason I start there is because I think it's the easiest place to find the plane of enucleation. Now, what you'll notice really important is I don't touch the tissue. I'm always about 0.5 centimeter away from the tissue. Now, this is important to avoid the carbonization that people always complain about. Carbonization has no clinical impact, but it is distracting when you're trying to find the plane of enucleation. So stay about 0.5 centimeter away from the plane. You can see I've already identified the plane of enucleation there. If you can't find it proximal to the verumontanum, you can also find it where the lateral lobe hits the floor, right there. You can see where that lateral lobe hits the floor of the prostate. So if you cut along that line and you just push ever so softly here, you'll see the lifting of that prostate. So that glossy portion here is the capsule. So this is capsule, and you can see very nicely here the adenoma and the capsule. Once you've identified that, you just want to follow it both ways, all the way to the other side, and then obviously all the way up and do the apical dissection. Again, staying away from the tissue and just really taking my time to lift up the prostate. So that's the first step, the crucial step, which is finding that plane of enucleation. So now we're going to start dissecting the apex of this left lobe, which I'll show you here now. So same prostate, just going up the side now. So the way you do this, so again, the apex, this is the key step in enucleation. If you can do the apex, you can do an enucleation. Is, first of all, you want to take your time, of course, but you basically just lift up the prostate ever so softly, and you'll see the little attachments right there, and you just cut along those attachments. Really, really important. Again, other thing that I did here, which you probably didn't notice, very subtly, I pull the laser fiber back. And the reason I do that is, again, to give me a little bit more room so that I'm not touching the tissue, so that I'm, again, not causing that carbonization. As you stay away from the tissue, the planes are much easier to identify. So again, this is the apical dissection. Now, I haven't showed you the sphincter adenoma separation, which I'll show you later on in the end of my presentation here. So just going, you can see really nicely capsule on the right here, adenoma on the left, and you just want to cut those attachments. That's all. That's all I'm doing, and I'm trying to get up to 12 o'clock. So here, I'm almost over the top here. Also really important, don't turn too quickly, because then you'll turn into the capsule. You really want to follow the, into the adenoma. You really want to follow the capsule and just dissect that prostate off of the capsule, and really, really stay on the capsule. If you stay on the capsule, you won't run into problems. So we've gone over the top now, and now we've gone over the top, and now we're going to head towards the bladder. So we're going to head proximally towards the bladder. Okay, so you'll see that here now. So now we're up top, we're at 12 o'clock, and we're looking for the bladder. Now, this is really, really important. You don't want to predict, I guess, where the bladder is. You don't want to just go straight and say the bladder's got to be here. You have to continue to follow the capsule. I just spoke to a colleague of mine who, ended up, just going, and he was saying, how he just kept going and going and going. He ended up, going, into the bladder neck, basically. You really want to follow the capsule, and what's going to happen is the capsule is going to start going downwards, and then you'll go into the bladder. But really, really important to follow the plane. So here I see the plane here up top. I see the plane here. So I always try to keep everything equal until I identify these perpendicular fibers right there. These perpendicular fibers are the last attachments of the bladder neck above to the prostate below. So once you see that, you know that on the other side of this is the bladder. But really, really important to follow the capsule until you've clearly identified where the bladder is. So prostate surgery, whatever prostate surgery you do, the bladder neck likes to bleed. So you want to take your time here at the bladder neck. But as you can see with this laser, there's not too much bleeding. The hemostasis really takes care of itself here. So just taking down the bladder now. Once you've done this part, I mean, the rest is quite easy now. The next part is just doing the lateral and posterior part. You'll notice that I use a lot of laser energy, or at least you should. When I started learning enucleation, I used to use a lot more manual traction to peel the adenoma off of the capsule. But here you can see I use a lot of laser energy. If you use the scope to peel the prostate off the capsule, which you can do, it's not a problem. The only thing is that when you do that, then it tends to bleed a little bit, which you'll see here in a sec. And then you have to go back and do the hemostasis. So here you'll see me pull on the tissue. It peels fine, but then you got to go back and use laser energy. So you can do either, but to save time, I use more laser energy than I do manual traction, as I used to do more manual traction when I first started enucleation. So when you're doing enucleation, I'll use manual traction ever so often if I'm not sure if I'm in the right plane, or just to confirm where I am. But once I know where I am, I usually use laser energy. Okay, so we've done the bladder, neck, no anterior commissure. Don't need to cut the prostate in two because we're doing the end block. So last step is the lateral. So the lateral portion, and then the posterior portion to basically flip up the prostate into the bladder. Here we go. So here's kind of, where you're going to speed up the process and really, end this thing pretty quickly. Once you've done the apical dissection, really, that's, the rest is pretty fast. So here, what you'll notice is I'm actually touching the tissue more. I'm not worried about anything now. I know where I'm going. I just want to get this prostate out now. So there is a little bit more charring because, again, I'm touching the tissue. I'm going faster than I was before, obviously. But the nice thing, again, with this laser, one of the things that I really like is the hemostasis. So ever so often, there'll be a small little bleeder. But for the most part, so here's a little bleeder, very easy to stop. But for the most part, this laser takes care of the hemostasis as you do the enucleation, which is really what I like and really what has kept me going with this laser. So that's it. Just go lateral to medial. I highly, highly recommend trying to go lateral to medial all the way down to as close as you can to 6 o'clock. Because whenever you're doing an end block, the difficulty in pushing the whole prostate into the bladder is the lateral portions, right? So if you can dissect out the lateral portions, then it's much easier to push it into the bladder. If you go straight to doing the posterior aspect or trying to lift up the prostate without doing the lateral sides, you'll have a lot of difficulties pushing the prostate into the bladder. So, really, really do as much as you can lateral to medial, and then you should be able to push up the prostate. So here I'm just lifting up the prostate now and pushing it up into the bladder. Again, try to recognize prostate tissue above and capsule below. This is really the key in enucleation. This capsule, it's subtle, but once you get the hang of it, you can recognize it pretty quickly, and that really will help you to do the procedure and not risk anything to your patients.
Dr. Bhojani, which size fiber do you prefer to use?
550 micron fibers is what I always use for enucleation.
Great, thank you.
Okay, so done that. Oh yeah, recognizing planes. So this is kind of sort of in line with what I've been talking about. Whenever you're doing an enucleation, it's really, really important to stay on the plane. So here, there's a little bit of tissue here, and you could say, oh, it's a little bit of tissue, no big deal. But you want to try to stay on the plane as much as possible, because as soon as you start leaving the plane and getting into adenoma a little bit, you're going to get lost, and that's when people get into problems. So see, that's capsule. You gotta recognize that capsule and try to stay on that capsule. So important. So I'm just trying to peel this little prostate tissue off, or this little adenoma off of that capsule, and you'll see I'm able to finally peel it off. And that's really nice capsule there. When you see that, again, you really want to stay on there and really try to continue on that capsule, and then really just don't get lost. I mean, it's one of the main things we hear when enucleation is when you get lost, when you don't stay on the capsule, you get into adenoma, and then it starts bleeding and blah, blah, blah. So you see that capsule there, try to recognize it and try to stay on it as much as possible. And then after that, it's fairly easy. I have another example. I think here it is. So this is doing the 6 o'clock groove. If you end up doing a 6 o'clock groove, a 5 o'clock groove, or a 7 o'clock groove, people always have trouble, knowing how deep to go. But the nice thing is, you can join up the groove with your initial incision, which was proximal to the verumontanum. So that'll help. But here, what I'm just showing you is cutting adenoma. That's adenoma here. That's capsule there. Again, just trying to recognize what is capsule, what is adenoma. I do apologize that it's a little bit fast here, but so here I'm peeling off the prostate tissue from the capsule. So there's a little bit of prostate tissue still left on this capsule. Again, just trying to help you to recognize adenoma tissue versus capsule. Here's a tough one. So there's like a nodule stuck to the capsule. So I'm just trying to peel off this adenoma or this nodule from the capsule. So the capsule is on the right-hand side. There it is. And that's the nodule right there. So this was actually a really tough one. I remember not all planes are equal. Some are super easy and some are more like this. So just trying to peel this nodule off of this capsule. Some prostates are nodular and those can be tricky. So I'm just trying to show you some of the more difficult cases. So there's the, just trying to peel this nodule adenoma off of the capsule. One thing that happens a lot is if you get into adenoma, you'll start getting to bleeding. So that's a good sign that you're not in the right place. If you're getting into bleeding, you're probably not in the right place. So here again, there's the capsule. There's some adenoma there. There's a nodule. So just taking my time and really trying to stay on capsule. Really important. If you get into something like this, let's say I'm doing the lateral left lobe, and I get into these kind of nodules, and it's tricky, and I get into some bleeding. What you can do is just go to the other side. So start enucleating on the other side. Just because one side is tough doesn't mean that the other side will be also difficult. So if one side's difficult, go to the other side, and then you can come around over the top and do that side, if ever. But oftentimes, if one side is difficult, the other side is actually pretty easy. So just a trick that if you have a tough side, you can always go to the other side. So again, just trying to stay on that capsule as much as possible. Another nodule there, but just take your time and try to stay on capsule, and you'll eventually get over the top of this thing and be able to get into the bladder.
We have one question from the audience, Dr. Bhojani. So have you done post-radiation SOLEPs, and are they more difficult?
Yeah, that's a great question. They are more difficult. Absolutely. I think you have to tell the patient when you're doing a post-radiation enucleation, regardless of the energy source, that their risk of incontinence is very high, just from the radiation, but also from a second surgery. Really, really important. But it definitely can be done. Less is more post-radiation. So if you can avoid doing surgery post-radiation, that's what I would recommend. But yeah, it can be done just like any other enucleation procedure. I wanted to. Is there another question, Mike? No. I wanted
the questions.
I wanted to just share this because I was hearing a lot of people talk about lithotripsy. So this is a 2.5 centimeter bladder stone. There's some chatter about bladder stones being difficult with the SOLTIVE Thulium fiber laser, and to me it makes absolutely no sense, right? Because one of the main benefits that we've the original SOLTIVE Thulium fiber laser indication was stone disease, right? And that's what everybody loves about this laser. So why would it not be good for bladder stones? I'm not sure. So this is a 2.5 centimeter bladder stone. I do a lot of bladder stones because these big prostates usually have large bladder stones. And you can see it's going extremely well. So the nice thing is I use exactly the same equipment that I'm using for my enucleation, using the same fiber size, so a 550 micron laser fiber. I'm using the same laser setting, so 1 joule, 60 hertz with a short pulse. And you'll see the other nice thing with this laser is that sometimes I'll hit the bladder. There, you just saw me hit the bladder there. There's no bleeding. And because it has a shallow depth of penetration, there's really very little risk if you just, graze the bladder mucosa. So again, same settings, same laser fiber. As soon as I finish this enucleation, I jump into, as soon as I finish breaking up the stone, I jump into the enucleation portion. Here's another one, two 2-centimeter bladder stones. Again, using the same laser settings, 1 joule, 60 hertz with this short pulse. And you can see it goes pretty good. I mean, these 2 stones took me about 12 minutes. Really, really important if you're doing bladder stones before you do an enucleation. you have to make sure you get out all the bladder stones. There shouldn't be any bladder stones once you're done before you start the enucleation, because when you get to morcellation, those little fragments can get stuck in the morcellator and can cause blockage of the morcellator, and you actually have to change your blades out and everything. It becomes really painful. So just make sure that if you're doing, breaking up a bladder stone before you go into enucleation, that you remove all the stones from the bladder, as much as possible. Prior to this, large stones like this is 4 centimeters of stone. I would do the bladder stones, for the first surgery. Then, patient go home. Then in the second surgery, I would do the prostate. But 12 minutes adds very little to my enucleation. So, it's very rare that I'll do this in 2 steps. I'll almost always do the bladder stones at the same time as the prostate enucleation. Okay, we're going to move on to advanced SOLTIVE thulium fiber laser. So far, the 2 main advantages of this laser for me is, of course, the hemostasis, which I've mentioned a number of times, and then treating bladder stones. But the laser in general, the SOLTIVE thulium fiber laser, is very versatile, right? So you already know that you can treat kidney stones. Obviously excellent for enucleation, excellent for bladder stones, but it's also good for soft tissue disease. I've done, stricture incisions, works extremely well. There's 0 to no bleeding, and then upper tract TCC. So, it's a really versatile laser, and these are the main things that I enjoy about this laser. So moving on to advanced SOLTIVE thulium fiber laser enucleation of the prostate, we're going to talk about large gland enucleation, sphincter adenoma separation, and then same-day discharge. So, so large glands, let's go here. So this is a 150-gram prostate. Let's move on. There we go. So 150-gram prostate. So the truth is, when you do a large gland, you're going to do it the exact same way that I showed. So you're going to start proximal to the verumontanum, and then you're going to try to find the plane of enucleation like we did in that first video. And if you can't find it proximal to the verumontanum, then you go where the lateral lobe hits the floor of the prostate. So really, it doesn't matter what the size is. You're going to do the same steps as you would do for any enucleation. The one difference is that if it's really big, you might not do an en bloc procedure. You might be cutting that prostate into 2. So the anterior commissure, and then a 5 o'clock, 7 o'clock, or 6 o'clock groove, depending on the anatomy of the prostate. So here I've located the plane of enucleation, and now I'm just kind of working it out to, around to make sure that I can basically identify it all the way around in sort of a horseshoe sort of setting here. So once you've done that, we go up this. So sphincter adenoma separation. So let's just go back here. We're going to talk about this in a few slides, but sphincter adenoma separation. So once you've identified the plane of enucleation, you start doing your apical dissection. It's here that we're going to separate the sphincter from the adenoma. So there's the mucosa, there's the sphincter. So about 1 centimeter or so proximal to the sphincter, I'm going to cut the mucosa and ideally the adenoma, so that I separate it from the sphincter. So the idea behind this is that the early incontinence that we get after prostate enucleation, we think is caused by stretching of the sphincter, which kind of makes sense. And the hypothesis is that we have not freed up the sphincter from the adenoma. And so the idea here is to free up the sphincter from the adenoma early on in the procedure, so that there's less stretching of the sphincter.
And one question, Dr. Bhojani. So how do you handle the very large glands where lateral lobes extend past the veru?
Yeah, great question. So those are really tough. And the Vero, I know that's kind of our landmark, but the truth is the sphincter is my landmark, right? So I'll pull back and look at where the sphincter is, and I will cut basically, like I showed you, about a centimeter proximal to the sphincter. So Vero, yes, it's kind of helpful, but it's really the sphincter. And so sometimes you have to cut into the adenoma a little bit if it's passing the sphincter, but those are rare. Passing the Vero, we see that, but passing the sphincter is rare. So really, I use the sphincter as my landmark, and I just cut, just proximal to that. So here's step 2. So we lifted up the prostate. We separated the sphincter from the adenoma just at the beginning. Then I lifted up the prostate a little bit more. Now I'm going to do it again. So here's kind of step 2 of the sphincter adenoma separation. So I'm going to come out here, and you'll see the mucosa that's still attached is over here. Now this is really important. We're going to talk about this, but anteriorly is where the most damage can occur to the sphincter, because the anterior sphincter almost melts into the adenoma. So this is where you really want to be more actually into the adenoma to try to preserve the sphincter as much as possible. And then once you've done that, you basically come over the top here and then head towards the bladder, like I showed you in the previous videos. Okay, get back here. So very large prostate gland. So quick word on very large prostate gland. So this is a publication by Mitch Humphreys out of Mayo, and this is using the holmium laser. But I just wanted to highlight, that you can do this for very large glands. If you're starting off, I'd recommend staying much lower than this, in the 80 to 100 grams. But these are really large. These are up to 300 and then greater than 300 grams. I mean, the average size in this group is 385 grams. So very, very large glands can be done. But you can look at the operating time was quite long, enucleation time, morcellation time, and then look at the conversion. So there were some, converted open cystotomies, conversion to open simples. So you want to be careful. And this is someone who's done, more enucleations than I have. So you want to be careful when you get up into those really big prostates, and don't do them until you're really comfortable. But you can see results are actually quite good. Complications, however, were quite high in this study. I was actually surprised, to be honest, but it was about 20%. His big thing was transfusions, which I was very surprised with. So just be careful when you get into the really, really large prostates. They can, be difficult. They can be done. This is really prostate size independent. One of the big advantages now is the morcellation efficiency, which is quite good now with the newer morcellators. But if you're going to do these really large glands, you got to have a plan B. So open simple to remove a gland. So the largest prostate I ever did was earlier on in my practice. Actually, it was supposed to be a 300 gram prostate. Enucleation took me about an hour and a half, which wasn't so bad. But after about 2 hours of morcellation, it felt like I hadn't done much. I had removed about 100 grams, but it felt like the bladder was still full of prostate tissue. And so I had to open and ended up removing in total 532 grams. So, the patient did really well, left the next day because really what's going to bleed is that enucleation part, So yes, we did have to open, but very little bleeding, right? Because we've already devascularized the entire prostate. The patient did really well. And like I said, the catheter came out the next day and he was fine. But so you might have to open if you have a really, really large prostate. Secondary procedure, sometimes if it's just too big, you need to come back. Just sometimes it's just tough. Not a big deal. You put in a catheter and come back and finish up the case. And then perineal urethrostomy. I've never had to do this. So really, really long prostates. If you can't get to the bladder neck, then you may want to consider this. Again, I've never had to do this. I've just had to push really hard sometimes, but never had to do this. But something to consider. So if you ever have to do that. So sphincter adenoma separation. So we talked a bit about this already in the large glands, but really, this is where you want to be working. So you have your sphincter here, your adenoma here, and there's that sulcus here, which is about, I usually go about a centimeter or two proximal to the sphincter here. This is just showing a little bit of the anatomy, and I think the key here is anterior. You want to be careful anteriorly because that's where sphincter damage occurs. Really, really important. Especially on the anterior lateral side. That's where injury is going to occur. So you want to be careful. I'm going to show you some videos, but you basically go up the sides. Separate the sphincter adenoma from the sides, and then up top, I usually go in even further to try to preserve as much as possible and stay away from that sphincter anteriorly. So just showing you again, highlighting the sphincter adenoma. So I'm starting this apical dissection. I'm going to be starting to lift up this prostate. And I don't do any sphincter adenoma separation just yet. I'm just cutting the mucosa, getting into that plane, and then I'm going to start to lift up the prostate. And when I start lifting up the prostate, that's when I'm going to start doing the sphincter adenoma separation. So here again, just lifting up the prostate, staying on that line. I've incised the mucosa before obviously getting into the plane, but I haven't separated the sphincter from the adenoma. So just lifting up the prostate. Again, the mucosa up here is still attached. So you're going to see me in a second here, turn my scope, and you'll see the mucosa that's still attached here. So this is all done, but in a sec here, I'll show you the mucosa that's still attached. Just want to stop some of these bleeders. So there's the mucosa that's attached behind me to the sphincter. And that's what you want to cut. So right there, you're going to cut that, and that's going to separate that sphincter from the adenoma. So this is how I do it now. This is not how I used to do it, or this is not how I was taught to do it. And I'm going to show you what I was taught to do previously. So this actually, I'm lining it up with the other side here. I'm going to show you what I used to do, and which, you can do, but it puts a little bit more stretch on the sphincter. Now, what I'm showing you is advanced enucleation. This is not easy to do. So there's the sphincter, and here is, the last kind of cut. And I try to stay away from the sphincter as much as possible, especially here anteriorly, because again, that's where you're going to damage the sphincter. Now, I'll just finish off here, go underneath, and then just cut this last little bit off. So this is what I do now, because, we think that this helps with early incontinence. Does it help? I think so, but really there's not too much data to support this just yet. We still need some studies to make sure, but again, this is advanced. Now, if you're not, I think I have one more video before I show you what to do if you don't do that. So so here's another example, same thing, going up the side here. So the first thing I'm going to do is cut that mucosa just to free it up. So I do this first step. This is kind of the step one. And then once I've done that, I'm going to go back in and then keep enucleating or lifting up the apex. And then I'm going to do it again, to free up that mucosa. Here it is. And again, this is, something that we think helps. Does it really help? I think so. I think there is less early incontinence. Definitely no late incontinence, right? So if you look at all the data, long-term incontinence is about 1% after enucleation, so very comparable with every BPH surgery. However, early incontinence, early temporary incontinence is higher with enucleation than it is with other procedures, I think. And one of the reasons for that is we don't separate the adenoma from the sphincter. So I think this is helping with that. And now I'm going to show you, if you decide not to do this or kind of do what I used to do when I was in fellowship. So let's say you decided not to do a sphincter adenoma separation, right? So you do your apical dissection, you go up over the top, then you go into the bladder. The problem is you've left this attachment between the sphincter and the adenoma, which is basically the mucosal, we call it the mucosal strip, right? And that's what's still attached. So the only way, or I guess one of the best ways to remove it is to wrap around the prostate, wrap around the prostate, as you'll see me doing here. So what I've done is I've gone around the prostate. I've taken that mucosal strip, which is still attached anteriorly. I've grabbed it. I've brought it all the way down. And then I'm going to pull back slowly and then cut it. I don't know why it froze right there. Oh, boy. Interesting. So this video doesn't seem to want to play. Let's try it again here. Yes. Okay. So now I've wrapped around that mucosa, brought it down, I've pulled back, and you're going to see the mucosal strip here on the left-hand side. So the reason we do this if you do this at the end is this way I'm away from the sphincter. There's no damage to the sphincter. But what happens is what you just saw there. Sometimes it's hard to maintain it under stretch and then cutting it. So you have to just wrap around again the prostate, bring that mucosal strip down below, pull back, and there's the remaining little strip. So the problem is when you do that, you stretch out, or the idea, the hypothesis is that when you do that, you stretch that mucosa, which is still attached to the sphincter. You stretch that sphincter all the way, down, and then you cut it. And so that stretch on the sphincter might cause some temporary incontinence. Okay, so we've talked about that. We're going to move on to the last subject, which is same-day discharge and kind of, how to get started. So we just published this. Actually, no, we didn't publish it. This is submitted for publication. We presented it at World Congress last year, just looking at kind of same-day discharges for enucleation. So this is using the SOLTIVE Thulium fiber laser. We were successful in 78% of cases. And this is, from when we first started with the laser until now. So that was until March 2022. But I can tell you that we're doing much better now. So complications, we looked at complication rate. So only 9% complication rate versus 23% in those who stayed in-house. ED revisits were lower. Readmissions were very low. So the results were really, really good. Very, very, we were very happy with the results, confirming what we had already seen clinically. And since then, we're much closer to 90% now. So most of my patients are going home same day of the procedure. I tell everybody they're going home same day of the procedure, and then we see how it goes. The only ones who are staying in house are those who come from far away, or if there's some sort of social reason where they don't have help, or sometimes the patients, if we do them late in the day, they don't have enough time, to start feeling their feet and getting out. So we're allowed to keep our patients in the recovery. After recovery room, they go to like day surgery until 9 p.m. in the evening. So sometimes if it's a little bit later, we'll keep them in overnight. But for the most part, they're going home same day. Catheter is being removed the following day. I don't remove the catheter on the same day. It can be done. I've done it. I just don't think there's any benefit, to be honest. If you ever have to put it back in, patients really hate that. And they feel like it's a failure, and it just doesn't make sense to me. But if you want to do same day, definitely achievable. Standardization is key. You want to make sure you do the same thing every time. Explain to the patients they're going to go home. And make sure that the team is aware. I used to have a size limit. I don't have a size limit anymore. When you start doing same day, probably start with 150 grams, probably be your max. Make sure that they have some help at home if they need it. Comorbidity, so the anticoagulated patients I still keep in house. Communication, really important. The nursing team, the anesthesia team, they need to know that the patient is going home. so that they can plan accordingly. Titration of the three-way irrigation, so that the patient, I also make sure the patients start drinking water as soon as they're able to, so that we can stop the irrigation quicker. Anesthesia needs to know they're going home, so don't put too many narcotics. And then I think hemostasis is the key. If you want to send patients home, hemostasis is the key, and this laser is the perfect laser to be sending patients home, because its main benefit is hemostasis. This is just showing you, at the end of the case, if the urine, looks like this, there's no reason why the patient can't go home the same day, So definitely same day is achievable. It's not difficult. You just got to make sure you make things, the same every time. And you'll be able to do it. How to get started? So ideally, you want to speak to somebody who has done enucleation, specifically with the SOLTIVE Thulium fiber laser. Give you some tips and tricks. I did that when I started. Learning curve. So enucleation in general, learning curve is about 20 to 30 cases, depending on how you're learning. I don't recommend, just figuring it out on your own. I try to get some help. At least someone you can talk to or email, or just so you can, throw around some ideas. If you're changing energy sources from something else to the SOLTIVE Thulium fiber laser, it'll take you about 10 to 12 cases to get used to the laser. So keep that in mind. Watch lots of videos, webinars, really important. Mentorship. So, Olympus offers mentorship. Olympus offers even, we're trying to do proctorships where, I can go to somebody's operating room. I think these are all really important steps towards, being able to do an enucleation. We just did a master class with simulators where urologists came. This is with Olympus, and we had hands-on with a simulator, a 3D printed prostate model, and I think those are, in the best way in my mind, if you're not, doing a fellowship, obviously, is, watch videos, webinars, figure out, the steps of enucleation, then, ideally use a simulator, come to a master class, then mentorship, proctorship. I think that's, ideal to be able to learn enucleation with the SOLTIVE Thulium fiber laser. To start, I think ideally something in the 80-gram range is ideal. You don't want to start with a small prostate. 40-50 grams, those are very difficult. You don't want to start with a huge prostate, because again, very difficult. The small ones are difficult because the planes are not as well developed. 80 is perfect. If you want, what you can do is try enucleating out just the median lobe. You have a patient with a large median lobe, so you do a 5 o'clock groove, a 7 o'clock groove, and then just lift up that prostate, that lobe, that median lobe. You do need a morcellator, obviously. And then you can do whatever you want with the lateral lobes. If you're a bipolar button or whatnot, you can do that. Try to find a prostate without a catheter, just because it's more inflamed with the catheter, and obviously no infection. So conclusions: SOLTIVE Thulium fiber laser, prostate enucleation. I think if you look, it's really exciting. There's lots of literature coming out on prostate enucleation. I definitely think it's the gold standard for a BPH surgery. I'm not saying it's for every patient, but it checks a lot of the boxes. If you're going to use SOLTIVE Thulium fiber laser for enucleation of the prostate, I think that the main advantage is obviously hemostasis. Bladder stones work really, really well. And then it's versatility of the laser. It's great for, kidney stones. It's great for bladder stones. It's great for enucleation. It's great for stricture disease. It's great for upper tract TCC. SOLTIVE Thulium fiber laser checks a lot of the boxes. So I think with that, again, thanks to Olympus for organizing this webinar. Thanks to all of you for attending, and it'd be my pleasure to answer any of your questions.
Yeah, we have a few questions, Dr. Bhojani, starting with what are the indicators for perforation, and how do you handle that?
Yeah, so again, the key is when you see the capsule, stay on the capsule. Perforations happen. Doesn't matter what energy source you're using. Perforations happen all the time. the key is recognizing the perforation. If you recognize it early enough, no impact. I still take the catheter out the next day. It's very rare that I'll keep the catheter for a longer period of time. If you get into a really big hole, which honestly has never happened to me, but just try to recognize it. If you see a perforation, recognize it, go in the right plane, and it shouldn't be a problem. Recognize what capsule looks like.
Excellent. And then what's your experience with SOLTIVE with anticoagulated patients? Any anticoagulations that must be stopped?
So I try to stop all anticoagulation. Aspirin doesn't bother me, but all of them. If I can stop them, I stop them. The only time I'll do it under anticoagulation is if the internist tells me I have to. And if you have to do it, you have to do it, and you can do it. I've done it. The problem, even when you can stop them, the problem is when you restart it, right? That's when they're going to bleed. So definitely can be done. It does work great. This bleeding is going to be a little bit more obviously than if they're not anticoagulated. But if I had an anticoagulated patient, I would use this laser because again, it's great for hemostasis.
Excellent. And it doesn't look like we have any other additional questions. But with that, I just want to thank everybody for attending tonight on behalf of Olympus. Thank you so much for joining us. And a special thank you to Dr. Bhojani for sharing his experiences and some tremendous videos. It was really educational and very entertaining. So thank you so much, Dr. Bhojani.
Thanks, Mike. Thanks, Lewis, and thanks, Steph.
Have a great night, everybody.
Good night.